on to our track 7, QIP on challenges in nursing resource management. A great ANEI patron, leader and veteran, Dr. Vimla Kapoor ma'am, Executive Committee member ANEI. Ma'am was supposed to chair this track, but due to unavoidable situation, ma'am is unable to attend this session. We really miss you, ma'am. However, I would like to take this opportunity to invite Ms. Leena Chandrasekharan, Executive Member, ANEI and Tamil Nadu Chapter President, who was kind enough to chair this session. Let's welcome ma'am onto this dais with a huge round of applause. Along with ma'am, I also would like to invite the jury, Dr. Jyoti Sharma, Executive Member ANEI onto the dais. I invite Ms. Usha Prabhakaran, Member ANEI onto the stage.
At this onset, I would like to extend our gratitude to the interim jury, Captain Dr. Usha Banerjee, Captain Madhukari Ray, Dr. Riaz Khan and Mr. Nijoy Peter for handpicking these gems with their QIPs. May I take this opportunity to introduce Ms. Leena Chandrasekharan, our chair for the session. She is working in the capacity of Head Nursing Operations in Dr. Mehta's Hospital, Chennai, and she governs the nursing services and quality. She also worked as the Chief Nursing Officer in Global Hospitals. She has accomplished her Masters in Nursing from CMC Vellore, and she has also published articles in Kerala Nursing Forum. A round of applause for Ms. Leena Chandrasekharan.
A very good morning to all ladies and gentlemen seated here. I take privilege in introducing our juries for the day. We have Ms. Usha Prabhakar, the Regional Nursing Director, Apollo Hospitals, Telangana Cluster. She is with 28 years of experience in health industry, an NABH assessor and assessor for QAI home care. She's been working in various capacities in corporate and government hospitals as Group Nursing Director, Chief of Nursing, Group Senior Director. She's got her alma mater is AIMS, New Delhi. She's also done her MSc Nursing. She's got various accolades. She's a recipient of the Ambedkar Excellency Award in 2023, Nursing Excellence Award in 2022, Best Leader Award in 2020 and Inspirational Leader Award in 2017. Very happy to have Ms. Usha Prabhakar as one of our juries. Our next jury is Dr. Jyoti Sharma. Do we have her slide? She is the General Manager for Nursing at Yashoda Hospitals. She has again worked in various capacities in many hospitals before her position at Yashoda. She's completed her Masters and she also has many certificate and diploma courses to her credit. She's been the recipient of Young Achiever Award in 2018, the Organizational Excellence Award in 2015, the Florence Nightingale Excellence Award in 2017. She's got many research papers and articles to her credit, and she's got 16 research scholars during her doctorate degree. She's been a passionate nursing professional, serving in administration and management, also partaking in quality projects and safety aspects. Happy to have both of them with us. Along with them, I'll also be one of the juries judging the participants. My first thanks goes to the interim judges, and thanks to all the chapter heads who had motivated our young leaders to present their papers. And we all know nursing challenges are around everything, and most often it is around resources. So how did we all battle this challenge which we face on day-to-day basis, sometimes it becomes a crisis for each of us. So thank you chapter heads, and thank you for all those people who have participated in presenting their QIPs. Though only 5 of them have been selected, all of them have done a very good job in telling us what exactly you have done and sharing your best practices to defeat all these challenges. Can we have our first presenter, Jyoti?
To introduce the first QIP, may we call upon Ms. Tinky Adhikare from Apollo Multi-Speciality Hospitals, Kolkata, who would be presenting on Inspired Care Comes from Inspired Nurses with title Challenges in Nursing Resource Management. Let's give her a huge round of applause.
Namaskar and very good morning to all of you. So I am very grateful and privileged to be here in front of such amazing people and organizers. For this opportunity, I would like to thank our boss, our Group Nursing Director, Dr. Captain Usha Banerjee, our Nursing Director, Captain Madhukuri Ray, and our CEO, Mr. Rana Dasgupta. And also, I would like to thank all of any members, any leaders, and all present here. So I have to give thanks to all the judges who have selected our topic. Today I am going to present our QIP Challenges in Nursing Resource Management. Yes, we know inspired care comes from inspired nurses. Challenges have been started from era 18th century during Florence Nightingale era. And we know our nurses, when they are doing during their shift 12 hours duty, nurses may take on a demanding workload due to staff shortage, endure workplace bullying, risk exposure to infection, and despite all these professional experience, still we loses the patient. During COVID-19, we have done one study. From there, we came to know that 93% felt stressed, 82% experienced emotional exertion, and 30% nurses left their job due to burnout, mental and emotional exhaustions. In spite of all these challenges, may seem insoluble, but all the nurse leaders and our healthcare experts focus on elevating nursing stress. Doing so can help prevent burnout, reduce medical errors, and improve patient care. So here are some of our professional obstacles we face. During unplanned and unauthorized absence, our must work double shift. For immaturity of our young generation, they have changed very frequently their schedules. They are very emotionally involved, extremely sensitive. They are prone to get illness due to excessive tension, and in order to cope, they engage in unhealthy lifestyles. Due to lack of knowledge about advanced nursing care planning, and they expose mental distress and infection. There was problem with skill mix, which created clinical deterioration of patient and poor clinical outcomes. During September 2021 till August 2022, our attrition rate was 3.5. So we have taken, as per the norms of the quality improvement project, we have taken 3 goals. We want to reduce the attrition rate, we improve the nurse satisfaction, and to improve the patient satisfaction score. Then we can be managed effectively our human resources. So as per norms, we have selected baseline data, and that data based on nursing attrition rate, nursing satisfaction score, and patient satisfaction score. As per QIP norms, we have to show our outcome with numbers. We have taken the methodology, DMAT methodology, where we have defined measures, analyze, improve, and control our problem. We have done the cause and effect analysis to know what all the challenges in nursing resource management. From there, we came to know we have the few points like lack of cooperation and coordination, lack of long working hours, lack of lack of process standardization on nursing human resource management, lack of resource, lack of knowledge about digitalization. We also see that what were the causes of nurses turnover. Their working condition and personal reason also came as notice. Problem solving approach we have adopted. We identify the solution, refine the solution and pilot the solution. Also hire, train, motivate and retain, we believe on that. We have categorized challenges with 7 R's and intervention we have given with 7 P's. Then our journey was enthusiastic, reliable, goal-oriented, organized, communicative and motivated. Then only we success our project. Our journey, first we have done the meetings for discussing all the gaps and the possible solution. We prepared the audit tools and we validate the audit tools from our respective department. We started data collection, then at end of the data collection we analyzed with the comparison of baseline data. Few strategies to curb the challenges: recruitment and retention policy. We have done the preceptorship program for new joiners. We have done the on-job training. Then we have adopted open door policy. We use the safety device. Then we have done the skill mix allocation. Then we have done the upward to downward channel of communication, what we call scrub made suits. Reward recognition program, and also we take care of acuity based patient care. We focused on recruitment. Previously, before project, it was fresher and experience ratio was more fresher and less experienced people was there, but now we have changed the ratio. We are taking more experienced nurse than the fresher. We have every year nursing satisfaction survey, and these surveys on the 9 points we have taken the surveys. First year 2021, when we have conducted the surveys, that time we have decided few of our manager needs to change their leadership styles. After changing the leadership styles, we have shown that aspect-wise nurses satisfaction score improve all the categories. Then we have continuous plan, where we have noted the all staff strength, competency and experience. Maybe they are working in different units, that whenever there is crisis we can pull out from the different unit to we can give the another unit. So we have started to take the consultant feedback, how our project is going on, that it can be checked our outcome through different type of feedbacks, the infection control rate and the average length of stay. If any patient going discharged without any incident, the consultant and the organization will be quite delighted with the nursing service. Now we have started to present our graphical representation, improve patient communication and safety. Start after the implementation of intervention, it is raised. We have remarkable improvement between set protocol and adherence protocol. We have checked all the evidence-based solution from nursing problems, which we can adapt in our quality improvement project. Then we have created one graph that is called control chart, which include mean, upper control limit, lower control limit, target and desired trend. And we can see here pre-project intervention phase and post-intervention phase, where the drastically reduce the attrition rate. Here the patient satisfaction, nurses satisfaction we have checked, and it is increased slowly. Then we have taken the patient satisfaction rate also, that also improved. So better strategic plan and outstanding original idea and excellent learning lever, the cultivation of a culture by the senior management and an annual operating plan all contributes to successful overcome challenges. The satisfaction of both nurses and patients was raised as a result of our strategic approach. The attrition rate is decreased due to the retention plan. Few glimpses of our activities. So way forward, we have to be adaptation of digitalization, artificial intelligence, strengthen our concept and specialized nurse and nurse practitioner, nursing empowerment and enhancement knowledge. So you can have best strategy and best building in the world. But if you don't have hearts and minds of people who work with you, none of it come to life. Thank you.
Thank you, Tinku. Do the juries have any questions?
That was well presented, Tinku. Kudos to you. All the three outcomes very well showcased, and you have come up with the saying that consultants' feedback has contributed along with the trainings in place, and attrition could able to come down drastically. Along with that, the nurse satisfaction, you said that it has been increased. What are the 2-3 things, if you can say, nurse satisfaction apart from the trainings, apart from the feedbacks?
They like the leadership and we are working as a team. They like that annual operating plan, which is the content of different type of engagement. Like staff engagement, they are doing the fun with a house activity. They are learning every 2 months interval SOPs. They are very prone to get that high risk process improvement, the levers. So whenever they are learning, they are engaged throughout their stay, and they are seeing that their career pathway is clear to them. So they are very happy with that.
Fantastic. Thank you.
Thank you so much. Very well presented. My only question is, like, during your training session, you use preceptors, right? So who actually your preceptors was? You're in charges, or you're having a different team of preceptors?
No, in the department we have the buddies who are not necessarily always in charges. We can give the senior nurses also along with the junior nurse. So they are and all the activities is monitoring by our education team and our operation team also.
And what ratio you maintain for preceptor versus nurses?
It's a 1:1.
Okay. Thank you.
Thank you, Tinku. It's great to note that you had used DMAIC. It's the 6 Sigma process. Want to know if you had set any significance level. Have you used any other statistics?
No, ma'am. Only we have collect the percentage of that every satisfaction score. So here only we have adopted the methodology of DMAIC. Here we are not adopted the significance level, because it is very knowledge is very related to knowledge, and where we are taking that significance level little different. So for that only we only taken the percentage.
Okay, was this slightly after the COVID?
It's yes after the COVID, but we have taken it up to 2022. So throughout 1 year. So for that only, it's both way. It is very improved our attrition rate. So now also we are continuing the process so that we can sustain.
So you are at 1.6 now. At the time of ending your study, how is it now?
Now is below 1, sir, ma'am.
Below 1.
Yes.
Okay, good. Any questions from the audience? Okay. We'll have our next presenter. Thank you, Tinku.
Thank you.
Can we give her a hand? Thank you, Tinku.
Thank you, Ms. Tinku. May I call upon the next presenter for today's QIP, Ms. Arpita Mondal from Institute of Neurosciences, Kolkata. Ms. Mondal would be presenting her QIP on managing attrition and absenteeism related to workplace injuries.
Very good morning to all of you. Thank you, my juries and all my seniors and my colleagues to be here. As we all know that today's challenge for attrition is huge. Everybody is facing the same problem again and again. Retaining your staffs, it is quite difficult and it's very challenging. So my project was on managing attrition and absenteeism related to workplace injuries. Me along with our quality team, we have done this project, and of course we have our mobilization partner, Team Arjo. They have helped us a lot with this project. So in the problem statement, if you see, work-related musculoskeletal disorders are responsible for morbidity in many working populations. Apart from the lowering the quality of workers' life and reducing the productivity, WMSDs are the most expensive form of work disability, attributing to about 40% of all costs toward the treatment of work-related injuries. WMSDs are also reported to cause lost work time or absenteeism, increased work retention, transfer to another job or disability than any other group of diseases, with a considerable economic toll on the individual itself, the organization and the society as a whole. At Institute of Neurosciences, Kolkata, the attrition rate was 50% in year of 2021. Considering COVID pandemic situations, the number was quite high. The number of attrition percentage was also quite alarming in the beginning of 2022. All the sick leaves were analyzed, and based on the finding, an audit was conducted to validate the problem of WMSDs. So we have adopted the PDSS cycle. In the planning phase, we had to understand the data. So we conducted the audit tool as well. We took an audit from the staff itself, and we analyzed the data for sick leave, attrition and staff challenges. We obtained the benchmark, and of course the review of literature was also there, and we had to formulate a strategy to stop this problem. In the do phase, we had a team meeting with the management. Of course, we had to present the data to all our management team to get whatever we want. Collaborate with the clinical specialist team, industry partner, to understand the patient handling solution, what are the things that are available in the market. Categorize unit or wards where patient rehabilitation is most challenging. For our case, it was ITU, HDU, as well as the rehabilitation unit. In the study and check period, we have found out that our patients' mobilization time mainly divides into two parts. That is 10 to 11 a.m. we used to mobilize our ITU, HDU and rehab patient to the units. From the bed to the chair and chair to other, standing and walking positions. In the evening as well, the timing was maintained from 4 to 5:30. And the bed first patient, mainly the patients who are on ventilator, tracheostomized patient who are on support, we used to move the patient if the patients are vitally stable. Patient parameters, of course, pressure injury, fall, and the contractures, etc. was monitored. Of course, we have to analyze our staff's ratio as well. What is the ratio for sick call-ins, absenteeism in each shift, we had to monitor. In acting phase, we had to create a safe patient handling ergonomics team within the hospital with the other team members, mainly with the physiotherapist and with our senior nursing team leaders as well. Partnered with the external organization that is need-based to implement the target set that we have. So the journey has started long back, and I thank Annie to give the opportunity to present this data, because I was quite confused what to do with this problem. So we started this journey in June 2021 and it is still continuing. So June 21 to December 21, we had a problem identification analysis of the audit data. January 22nd, in the year of 22nd, we had a meeting with the team management team, and in February 22nd to July 22nd, we had to implement the staff's safety culture. From August 22nd to February 23rd, we did the validation and adherence to the staff safety culture. So initially the phase that has come out, we have found that June 21 to December 21, total staff strength around this 6 month was 1,982. Out of that, we lost around 98 nurses, and staff on sick leave was 360. The reason for attrition, when we dig deeper, we found out that around 63% was the personal cause. Out of that, 37% was patient handling challenges. I call it a patient handling challenges because, as staff call in sick, we had to give a double shift to another nurse who is present during that time. So that causes extra stress, long-standing hours. That causes a lot of mental agony or a lot of physical challenges for the staff. When we analyze sick leave reason, work-related injuries further, among 187 staffs, we have found out that 72% of staff were suffering from back pain, 13% were suffering from sprain, injuries to the arms, shoulder, etc. And 10% of my staff has reported they have sleep disc problems. and 5% they could not take the stress of the work itself. So in the problem, in the work-related injury, we have reviewed other literature as well. As you can see in the graph, it represents that physiotherapists and the nursing staffs are the most vulnerable group who sustain the work-related musculoskeletal injuries. They predicted that sickness absence from low back pain cost a district health authority the equivalent of 60 full-time employees of every single working day. Manual handling operations, that is MHO, and the particular patient handling are believed to contribute to the insidious onset of low back pain problems for many affected nurses. Nurses are the most common object of healthcare workers was affected by MSDs. There was a study in Japan where they have taken feedback from 1,162 nurses. Out of that, they have found that 71.3% staffs were suffering from neck pain, 54.7%. Lower back pain was 71.3% and neck pain was 54.7%, and upper back was 33.3%. So how do you build the staff safety culture? First is the training. So we started with the ergonomics training by physiotherapists that was initiated in February 22nd to April 22nd. Hands-on training on ortho patient lifter by clinical specialists given in the month of May 22, and it is still going on for our new recruitments. Training schedule covered all the HCA, housekeeping. HCA is our healthcare assistant who helps our nurses in patient mobilization as well. Housekeeping, nursing and physiotherapist in all-month training calendar from February 22nd to August 22nd. Patient safety officer, team of physiotherapists, nurse team leaders, mentor juniors and other team members to help them and guide them regarding the patient shifting, lifting and transfers. Strategies with core ANEICON nursing team, quality nurse for ongoing nurse education program on safe patient handling was also taken place. Adopting technologies, extra patient slider provided in each floor by September 22nd to January 23rd. It was an easy task to do, so we did it immediately. Wheelchair with removable arm support was provided in critical care for the easy lifting of the patient and shifting from bed to chair. Procured 3 units of passive lifter for the 3 positions, that is supine lift, sitting lift and rehabilitation jacket for assisted patient walking. We procured all these 3 units in consecutively May of 2022, December 22nd, 2022 and March 2023. So in the improvement phase, when we conducted the audit from August and compared the data from 21 to 22nd, we found a significant decrease in the attrition because many of staff were leaving because they were having slip disc and other problems as well. Staff on sick leave was a huge number, so that also has reduced. When we analyzed the sick leave reason, once again we see that the numbers are quite high, 86%, but there is a correlation between the staff on sick leave. So the numbers are high, but the staff on sick leave's number are less. How is this possible? Because staffs were not suffering that much that they cannot tolerate or they cannot bear the pain. So the sick leave was reduced. And we know that once you have back pain, it does not go away so easily. So it will take time once they adopt all the technologies into their system. So out of that, sprain also has reduced, slip disc and work-related stress also has reduced in quite a number. So when we further analyzed the adaptation strategies and staff safety outcomes, culture, we found that 35% of our staff, they are very comfortable with the techniques that we have taught them and the instruments that we have provided them. The patient lifter they are very comfortable with is only 35%. 45% they were using it 50-50, like they were doing it for bed to chair lift and patient mobilization. 20% they're still in pipeline to adopt these strategies. Staff percentage motivation on patient lifter use for patient rehabilitation. 14% of staffs they have used it for the patient walking with the assistance. Sitting position lift was 52% and supine position lift was 34%. You can see the picture over here. The left uppermost corner. This is in our rehab unit. We put the jackets on the patient, and with only one staff, one will be driving the lifter and another staff will be assisting. So this pink dress is one of my healthcare assistant who actually is assisting the patient, and the person who is driving this lifter is our physiotherapist. Chairlift in ITU, this patient is ventilated and I require only 2 nurses to mobilize the patient from bed to chair, and this has to be done to have a better patient outcome. And this is training of our staff by industry partner Arjo. They have helped us a lot to adapt the technologies into our system. In summary, we understand that manual handling is estimated to be one of the main cause of work-related musculoskeletal disorders. In the healthcare sector, between 1,500 to 2,000 per 1 lakh workers were found to have MSDs. The incidence of work-related musculoskeletal injuries has been on the rise in all sectors of healthcare, among doctors, nurses, healthcare workers, and physiotherapists. Safe patient handling ergonomics team structure and support of all the department as one team approach is formalizing a safe staff strategy in our hospital has proved as effective outcome, be it from holding staff motivation, reduce attrition related to health issues, or give best practice to improve key quality indicators in patient. In way forward, we are planning to introduce 2 more patient lifters in ITUs and HDUs, plan to have regular ergonomic session, which is already happening, and plan to have motorized wheelchairs in the rehabilitation unit for the patient to give the patient independence. Just one fish with 2 lines, because this year Nurses Day we have celebrated with saying that our nurses are our future. If as a leader we do not think about our nurses' health, who is going to do it? So to make their life easier, to make their working environment better, we think we need to give them more hands-on, we need to give them more support so that they would not suffer from this kind of injuries, that they have to leave their work and stay at home. Thank you so much.
Thank you, Arpita. Any questions?
That was good again, Arpita. Very well presented. Occupational hazard is a very big contributing factor for the health hazards, hazards among the nurses and also the other healthcare workers. So you have said that it's a huge number of nurses got sick and they have a work-related injuries, injuries. That was a huge number. 37% you have mentioned as. Out of that, how many were there the serious injuries? Were all of them are minor injuries? Because you didn't mention cervical and
fewer minor injuries. Out of 10% were suffering from sleep disc problems. So they had to take long leaves and stay at home. So
what percentage was your disc injury? That
10%.
Could be a major
10%.
And cervical as well, including in that, or only the?
This was not cervical, ma'am. This is lumbosacral mainly.
Yeah, and you have mentioned as it's been improved only by manual handling technique trainings and gadgets.
Lot of ergonomics training was given, patient lifting, and we have introduced many gadgets, because neuro patients we get GV syndrome patients who hardly move from the bed after a long physiotherapy and long ITU care. They get out of the ITUs. We get stroke patients very frequently. We get other ICH, IVH patients as well. So, and we maintain a very strict protocol of patient, turning and positioning in the hospital. So, and all my nurses, they are very petite. Probably hardly they are 45 kgs and they are lifting a patient who is weighing around 70 to 80 kgs. So it's a very difficult job. Although we have very good numbers of healthcare assistant, but still, when we are lifting the patient or positioning change, it is very difficult for them to manage. So, yeah, it is helping a lot.
And the study was 6 months or more than that?
Ma'am, we have started this whole collection of the data in 21 August. We have started this data collection. And I had no plan actually for this program. It was to get and procure the machines and instruments. We have done this to present it in front of our management. So, it became handy this time.
Well presented. Shifting, lifting and training reduces the hazard.
Yes. Thank you. Oh, I'm sorry. Do you have any question?
only one quick question.
Yes.
Although you presented well, precise, very clear data. Only thing is like 360 is a huge number. The nurses who got such kind of sickness, right? The 360. So is any nurse was a part of your pre-audit assessments or something?
360 of the nurses. This is not entirely related to only musculoskeletal disorders. It was other calling sick also. But
360 in a duration of what?
360 it's 6 months duration. 6 month duration.
Thank you.
Thank you.
Yeah, question from the audience.
Is it allowed, please? Ma'am? Allowed?
Ma'am, I can hear you. It's okay.
Others have to hear you.
So yours is a neuroscience institute.
Yes, ma'am.
I would like to know, did you have a bearing on pressure ulcers because of this study?
Pressure ulcer, not really, ma'am, because we do have a single nurse or a team of nurses who looks after the pressure ulcers itself, pressure injury, to be frankly speaking. I have one dedicated manpower who gives round the clock, rounds to ensure all the patients, teaching patients, handling, everything is done. Ma'am, we have a 210 bedded hospital. So one nurse just dedicatedly for this. She takes the training of all our nurses, and we have in each unit we have dedicated nurse who looks after all the bed sores as well. So it has not, of course the shear and other injuries are less, but pressure injury as such, it is not so much.
So shear, do you have a data on reduction of shear
Yes, ma'am, we do.
related to this?
Yes.
This is a very important study that you have done.
Thank you so much, ma'am. Shear related injury has reduced a lot, ma'am.
Appreciation to your institution. I think it's a very great study, Arpita.
Thank you.
Thanks for caring for the nurses. A big round of
Thank you.
applause.
And I just want to mention one more thing. The hospital that I work with, the founder chairman is also himself a neurosurgeon. So anytime I ask him that I need this for my nurses, he never hesitates to give it. So that's why I got 5, 3 I got it instantly, all the 3 lifters, and 2 more is in the pipeline. So you can imagine it's each cost around 12 to 14 lakhs. So that is a lot of investment that has been given to us. Thank you so
Not
much.
alone that, your sliders and your wheelchairs, very good initiative by your hospital.
Thank you, ma'am.
Thank you for that study. We have our next presenter.
May I now call upon Mr. Vipin Peter from Fortis Hospitals, Shalimar Bagh, to present his QRP on an innovative method to deliver in-service nursing education.
Thank you, members of the jury, Annie, for giving me this opportunity, and a very warm good morning to everyone present here. Today, I stand before you filled with excitement and enthusiasm to present a solution that has the potential to revolutionize the nursing in-service education system. This innovative design has been carefully crafted to address the challenges we have faced and to create a more engaging and effective learning environment for our nursing staff. We all recognize the importance of in-service training. It allows us to communicate changes in protocol, identify areas of ongoing systems improvement, and introduce new evidence-based practices. However, the conventional method of providing this training seems to be burdensome and disengaging for our nurses. Picture this: nurses being asked to attend 1-hour sessions on the days of their evening duty, and to attend this they have to report 1 to 2 hours before their shift begins, and that too 4 to 6 times in a month. It's no wonder that the compliance of mandatory in-service training has been low. As you can see on this graph, although we strive to achieve a 90% compliance in 4 hours of in-service training, but what we were getting in the months, as you can see, is only an average of 55%. In some months it has even dropped down to 10%. the sense of compulsion that the sense of compulsion without real motivation has left our nursing staff feeling disengaged and burdened. During our interviews with the nursing staff, we discovered several reasons for this, and these interviews had to be very candid because if it was non-threatening, because the nurses know how they have to answer when they're given a questionnaire. So the reasons that came out was stress and burnout, short training sessions, and because of this, they actually felt that the trainings were impractical because they did not get time to do a return demonstration. They had lack of self-motivation because they are thinking about the assignment that they're going to get after the training, and they're thinking about inventory and all of that. So they had lack of concentration, poor information retention, and other things was that they always had this sense of added effort for coming to training. So this was happening 6 days a month. They have to report 2 hours early. And if you look at the training content, they felt that the content was repetitive and a little boring. And there was a lack of external motivation. They found that there was nothing in it. I mean, the question, what is in it for me, was unanswered. And so they always had this lack of external motivation also. And this was a major concern because this approach had, this was affecting their willingness to learn, but also hindering their ability to retain knowledge that they had acquired. I would also like to stress that during the COVID crisis, this issue had further exacerbated because we had nurses working 12-hour shifts, and although our trainings were online, the online attendance had also dwindled. So, our nurses deserve better. And they deserve a learning experience that empowers them, encourages growth, and ultimately improves the care they provide to our patients. And so we created the study day. It's a rostered day of in-service training designed to improve the way our nursing staff engages with education, with the primary aim of just increasing the willingness to learn and to improve attendance compliance to in-service training. This structured 9 a.m. to 5 p.m. session is filled with engaging lectures, hands-on demonstrations, case presentations, self-study modules, role plays, and interactive activities, keeping adult learning principles in mind. Imagine a day our nursing staff can immerse themselves in comprehensive and engaging learning experiences. A day where they can develop their skills, gain new insights, and grow both personally and professionally without the stress of thinking, what patient assignment am I going to get today? This is the power of study day. But what sets it apart? Each staff member is required to attend just one study day per month, and it is counted as a working day. They get a day's salary to attend this training. So no longer do they have to worry about juggling sessions outside their regular schedule. This change not only eases the stress and burden on our nursing staff, but also allows them to prioritize their learning and approach it with an enthusiasm and dedication. By implementing the study day, we have seen a remarkable improvement in compliance with attendance. The nursing staff are embracing this opportunity to learn and are eager to participate in engaging activities and interactive sessions we prepare for them. As you can clearly see, with the implementation of study day, the average attendance has risen from 55% to about 91%. This change is palpable. It has brought our nursing education team closer to the frontline staff, fostering a sense of unity and collaboration that is vital to our success. The impact of this transformation approach extends far beyond our training programs. It directly influences the quality of care we provide to our patients. As you can see in the slides, our patient fall rates have reduced, our hospital-acquired pressure injuries rates have reduced, medication errors have reduced, and accidental delinings have shown a reduction as well. In terms of infection control, we have seen a reduction in CLABSI and VAP rates. By empowering our nursing staff with knowledge, skills, and confidence, and we are elevating the standard of healthcare within our institution. The feedback has been overwhelmingly positive, with our nurses expressing excitement, motivation, and a renewed sense of purpose. As you can see that there almost 88% of respondents said yes, that it was meeting their educational needs, and as per whether they would like to continue with study day, almost 99% of the respondents said yes. This is how study day works. The education team, okay, so the first box here shows like what the basic categories of the entire day contains. You have sessions on communication, then you will have, depending on the training need assessment, we will have in-service sessions. Then there will be sessions on infection control, sessions on patient safety, nursing procedures, nursing documentation, and henceforth many interactive sessions, quizzes, things are also built into the program. And then for 4 weeks, a training calendar, a program outline is set. So because 4 weeks, so that we can have 28 topics in total per month. And then those study days are planned in the calendar, and these calendars are actually shared with the in-charges by 25th of every month. So the in-charges are aware of what the study days are, and they can roster their staff accordingly. We have been careful not to ask, we have given them an eligibility criteria. So team leaders, senior nurses, and administration nurses, and specialty nurses are excluded from study day. Only the young nurses, the ones who are new in the system, go through this process. In summary, study day has incorporated, because it's incorporated into the monthly duty roster, it has shown an increase in compliance. It is less stressful. It is a conducive learning environment. It promotes team building, because unlike induction, where you would have only the new nurses sit through, study day gives an opportunity for the new nurses to mix well with the senior nurses, and therefore the team spirit and camaraderie has also, we can see that. I mean, these are intangible benefits. The tangible benefits, as I just showed, was the reduction in infection rates and the quality improvement in quality indicators. But so we could see these evidently, and so that is study day. Thank you.
Thank you, Vipin. We have questions for him. Can we have the juries ask your questions before we move on to the audience?
Yeah, we've been very well presented, very innovative. Dedicated day is really good, that because the induction training or the on-job training and service trainings are really challenging, taking out the nurses from their bedside to a dedicated hour. If we take it out after the shifts, they are, burden up, and the distraction levels are very high, what you said. I completely agree. But what were the challenges? Like the dedicated day 9 to 5 in a month, only once in a month. Do you think that all the topics you were able to cover for a nurse for a 1 month, then the nurse have to wait for the next 1 month to repeat the topics or to come up with the new topics? Meanwhile, what about the incidents or the challenges nurse will come across? Because 9 to 5, how many topics you can able to cover?
Yes, ma'am. That's a good question, ma'am. So study day was not an alternative to on-job training. On-job trainings were continuously happening. This was just, yes, so the mandatory trainings. And the mandatory, so what we had done, as I had shown in the slide, we had 4 program outlines for a month. And so each nurse attends one study day in 1 month. The next month, she attends the other program outline, which was planned. So the study days were created for a 4-month period duration. And so the topics changed every 4 months. So each nurse in a duration of 4 months attends all the 28 topics.
Also slightly disagree with the not involving the in-charges and senior nurses. How do we conclude that they don't require this training? Was it any study base or anything?
Yes, ma'am. So from study day, the in-charges were excluded. In our unit, We have a session for in charges, specialty nurses. They have a session every Thursday. So we have, because their sessions, they have a G2. So the in charges have a member who can assist them. And so we had sessions for G1 and G2 on separate days. It's not as burdensome or strenuous for the in charges to come and attend a session. So we had 4 sessions for them every month, 1 session every week.
Congratulations, you've been very well presented. So, being an education background person, I work like this and we try to design like this, and we all are struggling with our in-service education. Doctor also wants to take the sessions, then there is a workshop, there's a other session, certificate courses. But what about that nurse educator and preceptor? So how many nurse educator, preceptor or clinical instructor you have who are taking care of all this?
That's a wonderful question again. So I have a team of 4 clinical instructors with me, and as you can see in the study day, we have incorporated, it's not just the nursing education team who's doing the sessions. We have physiotherapists, we have aligned with physiotherapists department, the biomedical engineering department. We have even aligned with the blood bank, the lab. We have the infection control nurse taking sessions on infection control, the quality nurse taking sessions on quality aspects. So each study day was a balance between all these sessions, and it was not burdening for the education team as well. So we had one clinical instructor even taking care of that particular study day, while the other clinical instructors did the on-job trainings and the departmental rounds.
Might be from your team, someone might be validate that study material, and only you're supposed to be.
Yes, the study material. So initially when we came up with this, the study material was used what we already had with us, but as we saw that the engagement with staff was increasing, we had to come up and we actually developed more training material for study days.
Thank you.
Vipin, I'm curious about 2 things. Did you involve your senior nurses and nurses who are interested to come up and present?
Yes, ma'am. This was also done. So we had nurses from the ER department, from the ICUs to come and do the biomedical training for the staff, fast protocols, the code, so many hospital safety guidelines were actually done by the senior nurses to present in this.
Okay.
So this
and in your satisfaction score, you showed us the attendance.
Yes,
The
ma'am.
attendance which came from your monotony, the previous one.
Yes, ma'am.
But after your study, you had taken attendance from your study day.
Yes, ma'am.
How could you compare those 2? Because study day attendance is totally different, and your monotony, that the regular CNE, the 1 hour CNE. So how did you compare those 2?
Ma'am, we have
Because this was 50 and that was 90.
Yes, ma'am. So, ma'am, we have a learning management software in our hospital, and so every time a nurse attends a training, their attendance goes into the software, and so it becomes easy for us to, at the end of the month, to take out how many nurses have actually done 4 hours of training or 5 hours of training. So the software helps us to get that information, and that's how we were able to do that.
We had some questions from the audience. Could you please put up your hands?
Yes.
I think everyone can hear me. I have 2-3 questions for you.
Can you use the mic here?
Yeah, I have 2-3 questions
Yes,
for
ma'am.
you. When you're talking about study day, I would say, for induction we take 1 full week, right? So how is the attention span of your team members? That's number 1. How do you do the evaluation of the effectiveness of that study day? And the third question to you would be, you were saying once in 4 months they cover, the entire topics are covered, right? So do you really take every nurse who's supposed to cover that 4 hours a month to 4 months? Do they really, they don't normally cover within a month. Looks like that, because
Okay.
in a study day you can't get everybody there, right?
Mm-hmm.
So that is the reason you are also doing it for 4 months, so that everybody covers everything. So how do you calculate that monthly requirement of training hours?
Okay. So, ma'am, I'll answer one by one. The first question was on their attention span.
Yeah.
And so keeping that in mind, if you would have seen our program outline, none of the sessions were more than 1 hour long. So we have, keeping adult learning principles in mind, we did not have just lecture and demonstration lectures being done in study day. We had interactive sessions, role plays were there were case presentations that we had to develop. And so those were created. Initially, we did have concerns about people saying that they don't have the stamina to sit through an entire day. But looking at the benefit that they're getting, they don't have to come for another 5 days for in-service training. They're getting paid for it. Eventually, I think they kind of got into the habit of study day. Right now, everybody is so pro study day that they want to actually, they look forward to coming for the days. The second question, ma'am, that you asked was, how do we evaluate? The focus that when we initiated study day was on their attendance. Slowly we had, when we presented this, the doctors started asking, how do you evaluate? So then we started creating a pre-test and a post-test for a 4-month period. So before the study day for that 4-month period starts, we have a pre-test. It's a short pre-test. We again wanted not to make it too theoretical. So it was a short pre-test, and we have a post-test also. Right now we are still kind of, because it's still evolving, we are still trying to find out what's the best way to evaluate the changes that study day is bringing. And so that is there. And ma'am, your final question was on per nurse. Yes. Ma'am, so because each nursing in charge also has the names of the nurses that they have, and when they send a nurse for, let's say, study day 3, the in charges also, we kind of trained the in charges on how to mark the nurses. So the in charges keep a track of, and we, the education department, also keeps a track because of the LMS software. We are able to see which nurse has done what part of study day. If she's done study day 3, she's finished study day 3, we know the next month she has to come for study day 2 or 1 or whichever is pending. And over a period of 4 months, she completes those 4 modules. In case somebody is new, they miss a module, it's not a problem because, ma'am, the topics are similar. They are general nursing topics which are necessary for everybody. They are not specialized. For specialized units, we have a separate program that runs within our education calendar.
One more question. We just take one more question.
Yes. Ma'am, this is an expensive project because every nurse gets a payment, and so we had to actually put our case forward. And before I talk about the expense, ma'am, there's a model that I wanted to share with everybody. There's the quality, time, and money triangle for for any project. And so basically there's a triangle. You have quality on one end, time and money on one end, and you can only choose 2. So if you choose quality and time, it's going to be expensive. If you choose quality and money, then you need a lot of time. So initially when we started this, ma'am, to answer your question, we had all nurses. We had around 440 nurses, excluding the administration staff, specialty nurses, OT nurses. We had 450. To get all 450 nurses to attend one study day in a month, we had to do 12 to 13 sessions in a month. And each study day has about 40 nurses coming into it. So we need an infrastructure. We need a hall, not as big as this one, but a big hall. We needed everything extra because our study day is going on. Other trainings in the hospital also should not suffer. So we actually have a nursing training room separate from our main auditorium. So there were a lot of challenges.
Yeah, that's what.
Yes, ma'am.
And only thing, how do you ensure that your batch, who attended the first section, they go to the second,
The LMS software helps us. Yes.
There is a question mark.
We have an Excel sheet that is prepared after every study day session, and so that keeps a track of the staff. Yes.
I think you have to be fast. We are running out of time. the last question.
Thank you for the nice study. Actually, you have given the satisfaction of the staff who attended. I've been on the staff who were on duty, whether they were happy that I'm not there in the study day because the others will be doing the extra hours or something. So how did you manage the work? That was my question. Thank you.
That's a very good question, ma'am. And to ensure that study day was successful, our HR team, our nursing head were very, they made sure that the nursing man force, the nurses were up, were to the mark. Because if ever there was a shortage of staff, the study day wouldn't be that successful because we would have lesser numbers of nurses coming for each study day. To make it successful, we needed at least 40 nurses to attend every study day. So we were able to achieve that only because we had adequate nursing manpower, and so that was one of the aspects that helped us.
Thank you, Vipin. That was a great study. You saw many questions being thrown to you. There are few more questions, but since we don't have time, please catch up with Vipin while he is having his lunch. Thank you, Vipin. Thank you, Vipin. We have our next presenter, please.
May I now call upon Ms. Arokya Jayadeepa from Madras Medical Mission Hospital, Chennai, to come up onto the dais and present her QIP on Novice Nurse Mentorship Program.
Good afternoon, all gathered here. It is a great pleasure to present my topic in this forum. Everyone discussing about induction and training and everything. So what challenges we are faced after the induction program? So we are talking to the basic structured training program we are given to the nurses. When you are coming to the ward, it is quite okay, they adapted everything. But when you are going to the, especially to the critical area, especially to the novice nurse, because of the fear, because of everything, they couldn't able to cope up the situation. They are trying to run from the ward. So what we thought it, we planned for mentorship program. So based on the criticality, dependency of the patients, 1:3 or 1:1 or 1:2 nurses and mentors were given to the novice nurses. We are given the training program. So the problem status, they study to assess the effectiveness of novice nurse mentorship program to improve the quality of healthcare delivery in critical care unit at selected hospital. Our objectives mostly, we want to know first whether the mentorship program is needed for the mentors. Next, once you are giving the mentorship training program, whether it is going to be improve the knowledge and practice, then whether that novice is getting the satisfaction. This is the major objectives of this study. So research approach, quantitative approach was adapted. The research design was a quasi-experiment non-equivalent one group post test only design. The setting of the study is the critical care unit in cardiac hospital. The novice nurses, those who are joining recently, 54 samples were taken. Then the sampling techniques, only novice nurses is a purposive sampling technique. So once the induction program is over, in person we are giving the questionnaire to the novice nurses. We asked whether in need for the mentorship training program. So most of them given for the positive answer. So because we enter into the thing, so only three areas we are focusing. We would like to give for the knowledge, then skill and reinforcement through the handout. But everything in the bedside. We are not taking to the classroom or the any area. Everything we given the training in the bedside itself. So our journey. So we started with the thing. For example, even we are going and asking to the nurses, this is the test tube, what we are supposed to do. It's very sad to share this in this forum. One of the nurse told we have to pour urine in this test tube. This is eye-opening for us where we are standing because the COVID batch, we can't blame them also. So we thought to give for the supporting hands to them. So we started this training. Meanwhile, we identify the problems and everything. The following slides, I share with you what are the area we are identified the problem of knowledge, skill and others. Then with the grace of God, we have the beautiful CEO with us. See, he motivated us to do for the more training program for the nurses. He given the open forum to us. It's the mentor of the CNO. Then we started this study. At last, the success was 3 areas we have the improvement. One is for the reduction of medication error, improvement of the documentation process. Third thing, the nurse got the satisfaction end of the training program. So the percentage I shared, so many areas are there. The key areas only I mentioned. What are the challenges we faced with the novice nurses? most of the time the novice nurses they face the challenges, the fear of the senior nurses. So we would like to break the things, break off the blaming culture to developing the just culture. So it is very this study was very helped us to do most beautiful things to the novice nurses. So with the study we analyzed the three important areas. One is what is the rapport with the nurses and the mentors. Initially they have the fears, they couldn't able to go and ask anything with the mentors. The days goes automatically the bonding was improved and rapport was improved. Because of that their clinical skill was improved, documentation aspect also improved, and quality of care also improved. So the alarming was the July, the more medication error, the 30% is not no harm, but the error was the omission and documentation error, then the administration error was happened. So when the mentorship program was started, they can able to do the things on time, they document the things that mentors keep on going and asking to the nurses whether you are given the tablet on time, whether you are documented. So they are giving the alarm to the nurses. It is helps them to do the things in very perfect. The next area, handoff time. Coming to the handoff time, two important things we did it. So basically the nurses is felt the stock checking and everything. All the critical area we created the sub-stores, and one of the pharmacists placed into 24/7. So it is help for the nurses to do only for the patient care. So then the traditional duty timings also we changed. So overlapping we kept it. So from the 3 hours it is drastically changed to 1 hour handoff time. In the same way, each phase we ask for the novice nurses whether the training is giving satisfaction. Because whatever things we are doing, we want to know whether it's satisfied or not. Then some areas, some of the novice nurses is given the name of the mentor's name. So even they are not facing some of the challenges, they are rude, they couldn't able to go and approach or everything. That time we call the mentors, we are given the counseling to them, so advise them, they change the practice. So again the word is we are encourage them to follow the just culture, we should not follow the blame culture. Even though we are giving the training and every area, some critical area we couldn't able to traditional practice and some of the factors we couldn't able to achieve the things, but most of the critical care area automatically the attrition rate was reduced. The nurses are staying with us minimum of 1 year to 2 years. So area of improvement, the way forward, first one, the mentors and the senior juniors relationship was very strengthened. Then better understanding how of the handling of the complication and emergency situation, improvement of the novice nurse skill, clinical skill, then drug errors and the handoff time was reduced, attrition rate is reduced. Then success factors, the rapport and trust between the nurses, mentors and the novice nurses. Substore we created in a critical care unit 24/7, strengthening of the novice nurse skill lab, demonstration, bedside teaching, case sheet review and case sheet study. Quality improvement process tool including team-based assessment, action plan taken multidisciplinary approach, doctors with the help of the clinical pharmacist and quality team. The challenge is what we are faced, very difficult to mentors to engage with the busy nurses, cultural practice that underdetermined provision of the comprehensive care, long-term follow-up is needed to evaluate the replication and sustaining of these early complications. Then one more important thing, recently I would like to thank our College of Nursing principal. We are introducing the integration training program. Ma'am also told we have our hospital have the skill lab. Even though ma'am is given the freedom, the college is shifted to near to the hospital. You can come and do the practice in that. So it is very help us to again give more practice. We can able to give more practice and training to the novice nurse, and we can retain them with us. Thank you.
Well presented, but a lot of pointers you have taken into it, and quantifying in terms of improvement, we could not able to see it because so many things you have mentioned. As a study, you have taken knowledge, skill, and others. In others bucket, I think so many things you have taken in order to, but we could not able to see it. But what do you mean of novice nurses? How long you will consider them as? Is it 1 month, 3 months, 6 months?
But first,
mentor program is for how long?
They have to finish the 15 days of induction program. Then we'll keep us a 3-month program. Then we will evaluate. If we are satisfied, independently we'll alert the patient. If not, again 3 months giving for the breathing time. Then we will discuss with the higher level with the CO. Based on the thing, we'll either we shift it to the EC ward or we'll take necessary action.
So the quantifying of that, how many of them because of this mentor program, the impact of that you could able to reduce the length or the knowledge more or the skill could not able to witness, but the organizational culture, what you are saying, it is hand-holding, mentee program and overall cultural shift, really liked it. Good work.
I want to appreciate you and your ma'am, as you mentioned that they are supporting you, but here you mentioned about mentor-mentee program. I just want to know what is the sample size you are supposed to maintain.
She said 54.
54 and mentor size. And mentor size. Like,
But again, based on that unit, we are designing for critical care unit, coronary care unit. Again, 3:1. In case of ventilator patient, we will give for the 1 mentor and 1 mentee. Stable patient, one mentor for 2 novice nurse.
That is for 3 months.
3 months, ma'am.
And evening and night.
Throughout, because we have the 50% of more than 5 years experience of staff nurses with us, ma'am.
so one mentor need to be take care of 3 mentees.
In case of very stable patient, in case of ventilator 1:1, non-ventilator 1:2.
And due to that, you said handoff can be reduced to 1 hour.
Yes, ma'am.
Was that any demographics available, like 3 ICUs you have taken for the studies?
Yes, ma'am.
And what was that, how many ICUs you were able to reduce? 1 hour
For
handoff
example,
from the 3 hours to 1 hour.
1 hour, because we changed the duty timing, overlapping timing. Previously we had 7 to 2, 2 to 8 and 8 to 7. Then during the study we changed the duty time of 7 to 1:30, 1:30 to 7:30, 7 to 7. So we have the half an hour overlapping time.
Thank you.
Thank you, Deepa. I think we have to move on to our next presenter.
Thank you.
Thank you, Ms. Arokya Jaideepa. Moving on to our last QIP for this session. May I now call upon Ms. Yamini Patil from Fortis Hospitals, Vashi, Navi Mumbai to present her QIP on recruit, recognize and retain.
Namaste everyone. Okay, so the last project, and I am very thankful to the organizing team and my own organization, my entire team who has worked on this project. Presenting in Hyderabad, RRR. Our project is Recruit, Recognize, Retain. The problem statement is the collaborative efforts to increase nursing retention of fresher nurses in a multi-specialty tertiary care hospital of Navi Mumbai. The background: nursing turnover is a global concern, but in year 2021-22, 50% of our joining nurses were freshers. Out of those fresher nurses, 37% of nurses had left us within 1 year, and out of those 37%, 82% of nurses had absconded. When a nurse is joining, there is a huge investment right from the recruitment till the training, till the nurse is becoming functionally capable and handling patient care. In that, if there is such a big number of absconding nurses, it was a big concern, and our team geared up to set an objectives to reduce attrition of the fresher nurses. We did root cause analysis, we planned measures to reduce this attrition, and our methodology was the PDSA cycles on the 3 areas. Our basic planning involved the root cause analysis of these attritions. Then we conducted nurse experience survey, and we did the brainstorming of these findings of these 2, and our PDSAs were in the areas of competency development, open communication, or having an open way approach, open door approach, where we also involved the trainings for supervisory team, nursing in charges, for the managing team skills as well as giving the constructive feedback. Our third area where the PDSA cycle conducted was on the employment engagement. On all these three areas, the study done based on again the nurse experience survey. We also monitored the nursing patient experience for the nursing care as well as the compliance monitoring. All the strategies that we are setting, how are we implementing that? That also we monitored and further actions taken. To highlight our journey, first in the recruitment, our focus was hire slow and counseling of a career pathway. As we couldn't change the situation of greater intake of fresher nurses because that's the best option was available and we had a intake of the entries coming where the fresher nurses. So this was the focus of hire slow and counseling of career pathway. Recognition. Recognizing that even a fresher nurse has a great contribution to patient care as well as recognizing their challenges, what challenges they will face, recognizing the importance of the work environment that fresher nurse goes through. And the third area was of retention. Apart from all the activities, we focused on the staggering of resignations. Resignations will keep coming, there will be abroad opportunities, there were higher educations, but we wanted to stagger so that if a bulk of nurses leave the ward, the remaining nurses, and if they are young nurses, they will have a great burden. So we focused on staggering, so it is helpful for remaining nurses as well as the nurses who are planning to resign. Coming to next journey of our open door approach, our first action was 555 communication, where senior leadership is involved to communicate with these new nurses on their 5th day, 5th week, 5th fortnight and 5th month of joining to know about their concerns. How are they learning? How are they comfortable in the organization? The feedbacks of their communications is communicated and addressed, as well as the capacity building of in charges done in the area of mental health first aid also, as well as the in-house counseling and clinical psychologist is also available. That facility is also utilized whenever required. The review of manpower is done at a unit as well as at the corporate level. That support is available even to also to the senior nursing team. Coming to competency development, very crucial for the fresher nurses. It begins with the blended induction program of 30 days, which also includes the communication area where the nurse patient and nurse communication, clinician communication is strengthened. They are helped that how do we communicate. It also includes structured explanation based on the common procedures like IV cannulation, medications. They are equipped with that. And specialty courses are not only for freshers, it is for all the nurses, senior nurses as per their interest, as well as including skill development certifications. As we carried out all these activities, we also were tracking our achievements. Our task was to reduce fresher nurses attrition, and our benchmarking we did based on our last 2 years rates, and it was 37%. We set a target to achieve at least less than or equal to 5% of the freshers attrition, that is 32%. And on the annual review, we could reach to some extent because our fresher nurses resignations within less than 1 year of tenure in our hospital reduced from 37% to 28%, and absconding of fresher nurses within less than 1 year time reduced from 82% to 33%. Overall attrition also had a good results, that from 43% to 22% of the attrition. I would like to highlight that in the year 2021-22, our intake of fresher nurses was 50%, and 22-23 our intake of fresher nurses was 76%. In spite of that, we could control the attrition and abscondees had reduced. This really displayed that there was a better connect with these young fresher nurses and our team, and we could give the substantial support for them. To summarize, there are other implications of this project. Our nurse-patient experience also improved from 71% to the 85%, and also we could see that our existing nurses are willingly inviting their juniors to join with us, and that also has further better hand-holding in the departments. We also noted that fresher nurses belong to Gen Z and they have very unique needs. Their work-life balance, positive work environment is very essential for them. We realize that recognize or praise in public and criticize in private, recognizing and rewarding good performance is very, very crucial to them. And we had to highlight this to our senior team who is from Gen X and Gen Y team. When we realized that this bridging the gap between the Gen X, Y, Z is one of the key time for the controlling the attrition. And way forward is sustain the efforts of recruitment, sustain the efforts of recognizing our young nurses, and sustain the strategies of retention is key thing. Retention is directly proportionate to people culture. It's not one day project, it's not a 1 month, 3 months project. We still have a big challenge, but sustaining all the efforts is the only key, and that's the only way forward we have. Still there will be many more challenges, but sustaining the effort by a large team of right from a senior body who is there with the fresher till all the other departmental heads. These sustaining efforts are important to control or have a challenge tackle attrition. Thank you. I thank everyone who has played a big role for this project. I am simply a representative mentioning here. Thank you so much.
Thank you, Yamini. That was a great study and for being so confident on the stage.
Thank you so much, Yamini. Well presented, very precise, very clear. And everyone liked RRR, of course, right? Yeah. So, and I would like to appreciate that you mentioned Gen Z because so many young nurses are here, and I would like to recall your leaders that we need to keep their recognition and their needs in our mind while we are recruiting and while they are going, of course, they are leaving. So we are here to take care of you. Thank you a lot. I just want to know that what methodology you used for your second R, which is recognition in a manner of challenges, in a manner of what they are facing. What kind of methodology you use?
Can I have my slide? For recognition, ma'am, we work mainly on the open door approach to have a continuous communication, because as 76% of our freshers was the intake. Even after the induction, we knew that they are going to handle the patient care. They are coming up with their procedures and all the challenges in patient care very soon. So having a good communication with them, having the nursing in charges were encouraged to develop a strong connect with their young nurses.
But daily we are connecting so many nurses, those are not very much coming up with the open door. So they are very inside their own. So you conducted some survey or?
Yes, our nurse experience survey was based on it was a link which was circulated them, and we maintained it anonymous, and we had communicated it that you feel free to give your views, feel free to give your suggestions, and trust me that the Gen Z is very, very open. They are not worried. They straight away put their points. We also had involved our patient experience team, who is totally a third person who will also have a big connect with patients. So they were also made vigilant. Any findings, any observations they have, they also could connect with us, and we have got feedbacks that they were little unhappy, that nurse was bit upset. Please find out what is to be done from one of the wards. So we could connect with them, and we could, that nurse doesn't know how we got the information, but we could counsel them. We had changed two of the nurses department, and that brought a big change. Initially, one of our in charge had felt, why immediately to change the department? They will become more demanding. But then we thought, let's give a try, let's check for another 15 days. If there is no improvement, we might know that this person is demanding.
Well, thank you. Well presented, Yamini. Very, very confident. Your total voice quality was really good. The way you have presented. Obviously, you have come up with the data and statistical number. You are much more focused on recruitment and training and obviously recognitions. And overall people culture needs to be changed, and 555 culture as well. But how about the retaining? Have you got any data in terms of your 2 years retaining, 5 years? What was the impact of doing this to enable us to understand the retaining? You could only stratified only with a 1 year retention. So your goal was what? Long-term retaining, isn't it? So any data representing or anything?
Yeah.
Any strategy or not?
Ma'am, if you check the data, as we reviewed the statistics, is very vague that we could get. One thing is there that our intake was fresher nurses. 76%, 50% was our intake. And we could see that our fresher nurses, where we are investing maximum, and they are absconding. After having a detailed induction, we are developing, we are teaching them hands-on, and after immediately that they are leaving without any information. So that was a very, very tough for even the senior team to continue these efforts. So we focused on those areas, because attrition is a very, very broad area. There was attrition of seniors, attrition of the in charges. Abroad now so many opportunities are coming. Even the senior in charges are having good opportunities in UK, USA. So if we try and fight all the battles, it will be difficult. So we had to focus on our young group, because our intake is very high in the area of freshers. So we had to take the focused actions for the problem area.
So the problem area, you have taken only the fresher nurses in your
Yes,
study.
here we have highlighted about
Only
the
on
fresher
the
nurses,
retaining of one.
but our overall attrition has also improved. There is a more than...
You
Yes.
did mention that you brought down to 28% attrition from the 37,
Yes.
which is good. Okay, thank you.
Thank you, Yamini. We come to the end of this session. I would like to thank our interim juries again for bringing such 5 beautiful studies on the stage. Dr. Usha Banerjee, Ms. Madhukari Ray, Dr. Riaz, and Mr. Nijoy. And can we have the presenters on the stage, please?
Okay. I request all the presenters, jury and the chair to pose for a group photo at the photo corner. Thank you so very much.